Good afternoon, faculty, class, and evidence-based clinicians all across the world. My name is Second Lieutenant Quan.
And I'm Ensign McGee, and today we will be presenting an evidence-based review on prevention strategies for chronic ankle instability. So let's begin by taking a look at the etiology of this condition. As we all know, ankle sprains are one of the most common injuries among athletes. And interestingly enough, the greatest risk factor for ankle injuries are previous ankle injuries that lead oftentimes to chronic ankle instability. As a matter of fact, after initial injury, 40 to 75% of people develop chronic ankle instability. And ankle sprains and chronic ankle instability are a highly prevalent condition. 10 to 28% of all injuries in sports are ankle sprains. So we'll start to look at a few of the articles that we reviewed. The interventions that these studies used were split into two main categories we found: exercise and functional rehab, as well as taping and orthoses. Lieutenant Quan will be reviewing the articles that looked at taping and orthoses, and I'll be taking a look at exercise and functional rehab. Within this group are three subgroups that we found: articles that looked at balance training, postural control, as well as proprioception and coordination training to treat chronic ankle instability. So the first article that we will be discussing is addressing balance training to treat chronic ankle instability. And this was a systematic review published in 2008 by Quan et al. And it was trying to answer the question, is balance training clinically effective for improving treatment outcomes in patients with chronic ankle instability? We've outlined some of the search terms that they used, including ankle sprain, functional ankle instability, etc. And interestingly, they only found 5 articles that met the inclusion criteria to answer this question. So among those 5 articles, it was unclear whether balance training among individuals with chronic ankle instability improved outcomes. And basically this just meant that there weren't enough articles that were well designed to address this topic. So the main point that we learned from this systematic review is there needs to be more research. Regarding the balance training intervention, there was one more article that we found. It wasn't the best designed study. As you can see, it was a non-randomized 2-group pre-test, post-test design by Razi et al. So non-randomized, so not the greatest, but nonetheless, subjects with self-reported functionally unstable ankles, as well as non-impaired subjects, both participated in dynamics balance training. The outcome measure that they used was a stability index, which they got from the Biodex stability system. And the results that this study found were significant improvements in balance within both groups, so a positive outcome for their chronic ankle instability with this study. So the next study that we reviewed was looking at a component of balance, specifically postural control. This is a prospective randomized controlled trial by Hale et al. They brought in some subjects with chronic ankle instability and tested them at baseline, and noticed that they had deficits in postural control as well as balance testing at baseline. They treated them with a rehab intervention, including neuromuscular control, range of motion, strength, stuff like that. And after the intervention, they found that their chronic ankle instability had improved balance and functional limitations. So their interventions addressed at improving postural control had helped their chronic ankle instability. Yet another piece of chronic ankle instability is proprioception and coordination. So we found a randomized controlled trial by Bernier et al. That used this intervention to treat chronic ankle instability. 45 subjects with a self-reported history of chronic ankle functional instability were randomized into 3 groups, one of those being the experimental group. This experimental group trained for 3 days a week for 10 minutes per day, and they performed balance exercises as well as proprioception exercises. After 6 weeks of this training program, they found a significant effect on modified equilibrium balance scores, however, no effect on the sway index, which measures joint position sense of the ankle. So a bit of mixed results, but it was encouraging that they found a significant effect on the equilibrium balance scores. Here we have another randomized control trial by Matsuzaka et al. That's looking at the intervention of proprioception and coordination training for patients with chronic ankle instability. 22 subjects were randomly assigned to one of two experimental groups. Ankle disc training, which is a functional balance sort of exercise training, plus tactile stimulation. So they were able to put adhesive tape right below the malleoli to give a kind of a joint proprioception piece to that training. So that was one group, and then the other group did just ankle disc training. This training was performed for 10 minutes a day, 5 times per week for 10 weeks. And both groups significantly improved their postural sway, so their postural stability. So ankle disc training was effective. However, it was interesting to see that the tactile stimulation group with that adhesive tape improved 2 weeks earlier. So this suggested that the difference could be to increased afferent input from skin receptors that were stimulated by this adhesive tape. So it was a very interesting article. So here we have a summary for some of these exercise-based interventions that we've looked at. Balance training, it could be effective to improve functional instability, but really we need more well-designed randomly controlled trials, and we saw that with the systematic review. There was decent evidence to suggest functional rehab can improve deficits in postural control, but like I said, still need some more articles for that piece as well. Pretty good evidence for proprioceptive and coordination training with that adhesive tape to improve functional instability. But of course, we really do need further research on this topic, which can be said about a lot of topics. I know what y'all are thinking. What about surgery? Here we have a systematic review that looks at just that. A conservative treatment, which was neuromuscular training mostly, was compared to surgical intervention to treat chronic ankle instability. They found 10 good quality randomized controlled trials. 3 of these trials found that a program in neuromuscular training appeared to provide short-term improvement in functional stability. 4 trials looked at surgical interventions, and really all they could find through this systematic review was that there was insufficient evidence to really support surgery. So their conclusion was chronic lateral ankle instability can be treated with or without surgery. It may be effective either way. We really need more studies.
Now that we've looked at chronic ankle instability and literature on exercise, let's now turn to orthoses and ankle taping. Let's first look at an article by Byron Hopt in 1998 that looked at the reduction of medial lateral sway, and another article in 2012 by Faraji et al. And that article looked at the increase in dynamic and semi-dynamic postural stability. The first article, back in 1998, looked at static stability, while the second article looked at dynamic stability. What both of these articles found was that orthotics had positive results as far as stabilizing chronic ankle injury athletes. In the Byron Hopt article, they took basketball players, 22 healthy and 22 injured basketball players, and they found that medial lateral sway was reduced in both populations. In the second article, they took 20 healthy basketball players and 15 uninjured basketball players, and dynamic and semi-dynamic postural stability was increased in both. And what they both concluded was orthotics had a significant effect on preventing future injuries for the uninjured population. In 2004, Papadopoulos et al. Wrote a review of literature on ankle instability and the effects orthotics had on it, and what he found was orthotics restricted range of motion and enhanced ankle proprioception. But what he also noted was there were very few articles that actually backed up the fact that orthotics might have a positive impact on proprioception. So he did encourage further research to be done on this topic. The restricted range of motion was actually a positive finding because what it showed was by having less range of motion, there was less chances of having an ankle injury. Currently, Short and long-term use of ankle bracing does not hinder athletic performance and may even improve it. In a 2002 article by Iles et al., he compared 10 different orthotics to find its effects on different types of ankle movement. And without going through all of them, he split them up into 3 categories. You have your semi-rigid and soft orthotics compared to non-conditions. And what he found was every orthotic, regardless of brand name and manufacturer, limited motion, limited its intended motion. But different orthotics served a different purpose. And what some of these shared in common was that the semi-rigid orthotics provided more stability. For pure restriction of eversion, it seemed the semi-rigid had a much better effect than the soft orthotics. But you have to take into consideration the type of athletes that will use these orthotics. So with that, this article broke it down into which ones provided what type of range of motion restrictions. And depending on the athlete, soft orthotics might be better suited. So if you have the PowerPoint in front of you, you can actually look at the 10 different orthotics, look at the name of the manufacturers, and know that orthotics 1 through 6 are soft, or excuse me, semi-rigid, and 7 through 10 are soft orthotics. So as far as orthoses is concerned, further research is very necessary. The 2004 Papadopoulos article suggests that there is a lack of evidence regarding the technique of brace application and specifically the effect of skin brace interface pressure on athletic performance and neuromuscular function of the ankle joint. In his article, he found that there is no effect of ankle braces on balance, isometric muscle power, and electromyographic activation of the lower leg muscles in static and dynamic conditions. Now that we've looked at the literature on orthotics, let's turn to taping. The suggested benefits of taping are very similar to those of orthotics: decreased frequency of ankle sprains and increased dynamic postural stability. But what was found in literature did not necessarily correlate the suggested benefits. For example, in 2010, Delahunt et al. Found that dynamic postural stability only have a perceived increase. While all the tests were non-significant as far as dynamic postural stability, all of their participants believed that they had increased stability. In a systematic review in 2008, Dyson and Reyes found that previously injured athletes have reduced lateral ankle sprains when using taping. But in 2012, Raymond et al. Found that taping did not necessarily correlate with increased proprioception. It is important to note that there were limited published trials investigating the effects of using external ankle supports in the prevention of ankle sprains. We know that ankle injury is more common when there was a previous injury associated with it, but total prevention of ankle sprains among those with previous injuries is not possible. Many more studies are needed to be conducted to find out how we can limit ankle sprains. Chronic ankle joint instability resulting from recurrent ankle injuries lead to joint hypermobility, proprioceptive deficits, muscle weakness, slow reflex response, and variations in the anatomy of the ligaments. The resulting instability can either be functional or mechanical, and taping and orthotics are two possible interventions that we can use to limit these mechanical deficits.
In conclusion, our evidence-based review indicates that a combination of a variety of exercise interventions combined with ankle and foot orthoses as well as taping could all be effective depending on the patient that you're working with. And of course, there's always a need for more research. Thanks for watching, and have a fine Navy day.